with resuscitation, there are several different ways that we get to the point where we need to perform resuscitation, but generally you're looking at shock, respiratory failure, and then a subsequent arrest, and cardiac failure and arrest are all kind of the results of a final pathway of inadequate perfusion. So, like I said, lots of different underlying causes of those conditions, but they all have the same priority pre-hospital: restoring the conditions for aerobic cellular metabolism. Without this, we tend to die. So the series of interventions used on those patients is what they call resuscitation. So when resuscitation is required, it means that the patient has a life threat of some sort. So, with your resuscitation, it may seem like you need a lot of quick action and can be kind of stressful at times, but there's a couple of different keys that will help you understand your priorities and focus the priorities on that situation and be able to have effective teamwork and use your skills critically to meet that patient's needs right there. There are certain algorithms, but they don't account for every single aspect of every single situation. So teamwork is key, and that is actually the focus of the last 2015 American Heart Association Guidelines for CPR and Emergency Care. And I imagine that coming out with the new guidelines will also have a focus on teamwork. Establishing a team leader is important, Ego has no place in patient care. It's all about the patient's best chances of survival. Everyone needs to be able to make suggestions without fear of reprisal or payback or anything like that. And everybody needs to be willing to listen to suggestions. Everybody makes mistakes. Sometimes people have different opinions or input that may be beneficial. So teamwork is really important, and it takes practice to become a good team member to work with other people. So when we're looking at cardiac arrest, and that's typically what we think of mostly when we talk about resuscitation, in your adults, your sudden cardiac arrest is most likely to cause from some kind of primary cardiac problem, so like an acute coronary syndrome or a cardiac dysrhythmia. In young adults, it may be like a genetic abnormality, especially like with your young athletes and things. And then in children, it's fairly rare, but usually is going to be secondary to some kind of respiratory failure. And then, of course, there's some other, odds and ends cardiac arrest from trauma, hypothermia, overdoses, electrolyte imbalances, strokes, embolism, things like that. So sudden cardiac arrest is when the heart develops a dysrhythmia that does not produce a mechanical contraction. And so what we're looking at is electrical and mechanical there. And electrical is what we look at on the EKG. And you have to have sufficient electrical to produce a mechanical pulse to generate cardiac output, because if that muscle's not squeezing and putting that blood out, then perfusion is going to stop. And when perfusion stops, that patient becomes pulseless, unresponsive, and apneic. For the purposes of resuscitation, agonal respirations are also considered to be kind of a side note to your apnea, because even though they do have some breathing effort, it's not effective and it won't last for long. So that is also considered to be under that blanket of apnea as well. So once perfusion stops, tissues become ischemic. The only way the patient has a chance of survival is if we can restore perfusing rhythm before extensive cellular damage occurs. So what we're looking at here, about 25% of the time, that initial rhythm in your sudden cardiac arrest is going to be what they call a pulseless ventricular rhythm, which are going to be ventricular fibrillation or VFib, or ventricular tachycardia or VTAC. Right? There's some other ones, asystole, pulseless electrical activity, things like that. But what we're looking at is what the underlying rhythm or problem is. Right? Regardless of whether it's a sudden cardiac arrest or not, once this initial treatment started, we're going to try to develop these hypotheses about underlying conditions and some specific interventions that we may perform to try to negate any of these detrimental problems that could be underlying. And we will come back around and hit those H's and T's. We'll come back and talk about those in a few minutes. So when we're looking at treating cardiac arrest, goal, of course, is restoring perfusion. So the AHA has this thing called the chain of survival. And basically, these are all links in a chain. Cue Aretha Franklin there. But if any one of these links is missing, then the odds of survivability go pretty much out the window. So your links are going to be immediate recognition. In other words, somebody has to recognize this person's in cardiac arrest. Right? You need early, high-quality CPR. You need rapid defibrillation. You need basic and advanced emergency medical services and transport. And then you need in-hospital advanced life support. And so if any of those things are missing from that link, the odds of survivability drop pretty significantly. Resuscitation from cardiac arrest is most likely to be successful if defibrillation is performed within the first 5 minutes after collapse. I mean, that's for the patients whose initial rhythm is a VFib or VTAC. Now typically the interval from collapse to arrival of EMS with the defibrillator is usually longer than 5 minutes. So this is why there's a big push for public access defibrillators and having them at different locations. Now, sometimes when you get dispatched, it's a cardiac arrest. They'll tell you CPR in progress, whatever, going into it what it is. Other times, you may not know exactly what you have when you get in there. But you may arrive and somebody's doing CPR, maybe somebody's not doing CPR. So what we have to do is look at and see, because not every unresponsive person is in cardiac arrest, but we have to be able to quickly determine if they are. So sometimes this general impression of an unresponsive patient may be cyanotic or mottled skin, and then immediately, hey, they need resuscitation. All right? If it's not apparent, if it's not immediately obvious, we're going to check responsiveness, breathing, and a pulse. If that patient is unresponsive and has apnea or agonal respirations, check carotid pulse. Except for in pediatrics, less than 1 year old, then we check a brachial. If we do not detect a carotid pulse within 10 seconds, we start compressions. Okay? If they respond to our voice or painful stimulus, or if they're unresponsive and they have breathing except for your agonal respirations, they're going to continue with that primary assessment like we normally would. Okay? The most important element of cardiac arrest treatment is that initiation of chest compressions, and once this arrest is recognized, compressions must be started. Right? Normally, when we look at the patient assessment, we're going ABC, except when we need to restore perfusion for your cardiac arrest patient. So once cardiac arrest has been identified, the sequence of patient care goes to CAB, circulation, airway, breathing, with the emphasis on compressions. The reason behind this is when sudden cardiac arrest occurs, a certain amount of oxygen is still in the blood and in the lungs. When deoxygenated blood reaches the pulmonary system, it's not unoxygenated. It still has a decent partial pressure of oxygen, about 40 millimeters of mercury. But after a normal exhalation, the lungs contain about 2,200 milliliters of air that can continue to exchange gas or exchange oxygen with the blood. It's not ideal amount of oxygen available, but it's better than none at all. So with your immediate high-quality compressions, it can restore a minimal but critical level of circulation. Another reason that we want to do chest compressions first is that when done correctly, they create negative and positive intrathoracic pressure to fill the heart with blood and then squeeze it back into circulation. At the same time, these changes in that intrathoracic pressure also are going to allow just a little bit of air movement in and out of the airway if it's open. So artificial circulation produces about 21% of normal circulation, but it may be enough to sustain minimal perfusion temporarily while the underlying cause of the cardiac arrest is corrected. Now, defibrillation is a big component of survivability, or of CPR in general. Early defibrillation is critical for those patients who have a pulseless ventricular rhythm. They have a higher probability of survival than those who are in who are in asystole or PEA. Okay, but that window, it closes pretty quickly, so early defibrillation is important. To maximize the chances of successful defibrillation, we want to make sure that we keep chest compression interruptions to an absolute minimum. Right now, if you ever watch somebody be defibrillated on TV, it's restarting the heart or something like that, and it's very big and dramatic, and they shock flatlines. That's not how it works. Okay? During defibrillation, an electrical currents pass through the heart to depolarize the cardiac electrical cells uniformly, and so stop them from working independently. It actually stops the heart momentarily. Then, hopefully, the myocardium and the conduction system can repolarize uniformly and hopefully establish, with the SA node regaining control of the heart and establish a normal rhythm there. Now, your defibrillators, come in 3 operation designs. They have manual, semi-automatic, and automatic. Your manual defibrillation is going to require pretty significant training in the recognition of dysrhythmias and allows that operator to control completely everything over the timing and electrical use used in defibrillations. And these are the ones that you will see in the hospitals and with your paramedics. Now, your AEDs and your semi-automatic AEDs are going to be, most often they're referred to as just AEDs. They're kind of referred to one and the same, but there's a big difference that you need to know about. So the semi-automatic external defibrillator advises the operator that a shock is indicated. So you must then push the button to deliver the shock. But an AED, a true AED, determines the shock is indicated and you don't have to do anything else. It delivers the shock itself. Most advanced EMTs and EMTs and EMRs are going to use the semi-automatic defibrillator versus your automatic defibrillator, which is usually seen in public places. Okay, so with your AED, when you're using the AED, a couple things have to happen first. They require preventive maintenance to make sure that they are ready to go. So you follow whatever their manufacturer regulations are and adhere to your employer's policies. You need to check the AEDs, check the batteries, check the defibrillation pads. They do expire. When we apply an AED, we only put it on a patient who is in cardiac arrest. We never apply it to somebody who has a pulse, ever. Never, ever, ever. They must be pulseless and apneic. All right. If a defibrillator is available, apply it, use it as quickly as possible, but with minimal interruptions in chest compression. Okay. AHA does recommend performing CPR while waiting for the preparation of an AED, but not delaying defibrillation in order to continue compressions once that AED is there. Now, your defibrillator pads are going to be adhesive and conductive, so what that means is it allows the rhythm to be detected and the energy to be delivered through those leads. So we're going to connect the pads to the AED and apply them to the bare chest following whatever their recommendations are for placement. If placement's not provided, then one pad is on the upper right chest beneath the right clavicle, and the other one is placed in the left lateral near the apex of the heart. Make sure if there's breast tissue, the pad is placed under that breast tissue. Also make sure if the patient is wet to wipe the chest dry before applying the pads. You need to make sure that you have good skin contact with the pads. If necessary, use some kind of safety razor to shave any excessive hair. And in severe cases, if you don't have a safety razor, you can even use a spare set of pads to remove excessive hair. Apply the pads firmly to that chest and then rip them off to pull away any hair. We don't put pads over jewelry or medication patches. We're going to remove any items like that before we attach the pads. Okay? We are not going to place the pads directly over any internal implanted pacemakers or defibrillators. Okay? Now, with our IV access and medications, CPR, defibrillation, and airway and providing ventilations all take precedence over your IVs and medications. Even in ACLS, the role of medications kind of de-emphasized a little bit, and IVs are only established when you have sufficient personnel and you can do it without interrupting or delaying more critical procedures like compressions or defibrillations. So an IV may not be established until you're en route or at the hospital, and that's okay. All right, IV fluids have not generally shown to improve cardiac arrest outcomes and generally are not required. The only time you really want to consider significant amounts of fluid is if the hypovolemia is the cause of or contributing to that cardiac arrest. As far as resuscitation, in order to have successful discharge, you need to be discharged from the hospital with your, neurologically intact. And that doesn't happen very often. So the things that we're looking for, those other causes, those differential things that we want to see if there's any underlying causes we can correct, they're H's and T's. So that's going to be hypoxia, hypovolemia, hypoglycemia, hypo or hyperthermia, hydrogen ion, which would be acidosis, or alkalosis, hypo or hyperkalemia. And then your T's are going to be trauma, toxins, thrombosis, which clots, tamponade, or tension pneumothorax. Those are all things that are potentially reversible. Doesn't mean that as an advanced you can reverse it, but it's something to think about. Now, some other things to look at, and not every code's going to be worked. There's sometimes when death is obvious and there's no need to do resuscitation, and you've got to follow your protocols for when resuscitation is or is not indicated. But typically, you're not going to initiate resuscitation on a patient who has rigor mortis, or that stiffening that develops after death, if they have dependent lividity, if they have obvious decomposition or other injuries incompatible with life like decapitation, transection of the torso, things like that. All right. The survivability rate for traumatic cardiac arrest is very, very low, and a lot of systems actually discourage starting CPR on trauma patients without a pulse, especially if they have blunt trauma. Terminally ill patients may have physician's orders for life-saving treatment meaning maybe withhold CPR or other aspects of it, and your protocols are going to specify how to determine whether it's valid and what you should do in each of those situations. An important thing to remember too is that for us, this may be a clinical event, so it may be just another day, but for this loved one of the family members, it's the loss of a loved one, and it's dramatic for them. So make sure that you delegate appropriate resources to look after their well-being as well. Which, me personally, I find that more difficult than dealing with the dead folks. But it needs to be addressed and needs to be handled. With your ROSC, or return to spontaneous circulation, it is not frequent at all. Some patients do have ROSC, and you've got to be prepared to manage these. I've done CPR on hundreds of patients over the years, literally have lost count. I know of 2 that made it out of the hospital neurologically intact and are out living their lives. So it's not a very high percentage at all. Our pre-hospital treatment usually is not going to address the underlying cause of cardiac arrest very well, which means that the patients with ROSC are at high risk for second cardiac arrest. So you must monitor very carefully for subsequent arrest. Most of them are going to remain unresponsive, although it is possible to regain responsiveness. Typically, we're going to manage the airway fairly well and fairly aggressively. We're going to manage the breathing. We might want to consider placing an airway adjunct if it's indicated. We may use positive pressure ventilation as indicated. Keep that AED nearby in case you need to shock them again. Don't take the pads off. Leave them on. Okay, try to maintain their body temperature. And if they're hypotensive, we may want to consider a bolus of IV fluids as needed. And then, of course, vital signs and your head-to-toe assessment. Use your monitoring devices, pulse ox, capnometry, blood glucose if you haven't already gotten all of those.